Great. Well, Nick, thanks very much for that introduction. It's very generous and kind of you. I think the important thing to say really here, we're unusual in a department of this size to have 3 hand surgeons. So in a DGH, it's very unusual to have 3 hand surgeons. And what's good is that we all get on and we work well as a team. So we share an office, we have a meeting every week. And it really means that if you refer into us, then you're not just getting one of us, but 3 of us. We're all fellowship trained. Several of us have got hand diplomas. And we're doing quite a lot of things that you wouldn't necessarily expect a district general hospital to be doing. So this talk is prepared with my colleagues, and some of the slides are borrowed from them. So hand surgery is a massive topic. I can't teach you all of hand surgery in half an hour. Hand surgery is a multidisciplinary specialty with elements of arthroscopy, replacements, tendon work, bone work. And really, if you have a single thing to think about when you're trying to put a framework on how to look at hands, it's all about function. So with the patient in front of you, depending on whether they're a musician or whether they're a rock climber, whether they're doing very manual work or very precise work, will really depend both on what they do to their hands and how you then treat them. So if you have one thing to think about with a patient in front of you, it's all about function. And so as a way of framing this talk, I thought I'd try and break it down to things that then affect function. And so hopefully then just give you some things to sort of either pin diagnoses on or to have plans for things. And as has been said, if at any point any of this doesn't make sense or you have questions you'd like to raise, then just shout out. And this is really based on things that either have been referred into me or I see commonly in clinic. So, so the first of these things is people with bent fingers. So it's quite common for me to see patients in clinic with Dupuytrens. I suspect all of you have seen patients with Dupuytrens. It's the most common heritable disorder affecting connective tissues. It's inherited, it's benign, it's chronic and progressive. And you get this fairly classical picture of a patient with these cords in their hand and fingers that don't go straight. For those who are interested, it's autosomal dominant. But one of the important things is a misconception that it's to do with the tendons. Patients will often say, oh, it's McGlider's dot, which was a term I hadn't heard of until I came to this part of the world. And it's nothing to do with the tendons at all. But because you get this cord-like structure that looks a bit like a tendon, it's not uncommon for people to say there's something wrong with my tendons. But you get shortening along lines of mechanical tension, and that then affects function. There's a small group of people who've got a positive family history. It affects both of their hands and it affects other parts of their body, so the soles of their feet, or they get Peyronie's disease, and those people do worse. So they tend to get recurrence early, they tend to have more aggressive disease, and it's worth knowing about them sooner rather than later. But the conversations you have with them are really all about function, because quite often they'll get recurrence and need something else doing. So you'll have probably all seen this kind of thing. Patients with it starts off with a small nodule in the palm, and then you get an associated cord, and then that pulls the finger down. And patients will often come in volunteering that they go to shake hands, and people think they're in the Masons, or they can't let go of door handles, or it just gets in the way. They poke themselves in the eye when they wash their face. So functionally, having a bent finger is really problematic. You can label the different cords depending on where they are in the finger, but essentially you get it's abnormal tissue that's then laid down, and the myofibroblast, which is the cell within that, contracts and pulls the finger into a funny position. What you really want to know from me is, well, what do we do about it? And the question is, at what point do you do something about it? And the key intervention threshold is this recognition that if you can't put your hand flat on the table, that causes a problem. So Houston, who was a surgeon in Melbourne a while ago, described his tabletop test. But basically, if you can't put your hand flat on the table, you can get a biro beneath it, then that often is the threshold at which we'll do something. The thing to say around that, though, is that MCP joint flexion is often tolerated much better than PIP joint flexion, and particularly from a surgical point of view, as soon as people start getting PIP joint flexion, I want to know about it, because once they get really flexed, you have to tell them that you can get it in a better position, but you can't make it normal. Whereas a very flexed MP joint, you can sort of get back to normal pretty quickly. And a lot of that's to do with the geometry of the MCP joint, which is more cam-shaped, than the PIP, which is more round. So basically, this kind of contracture is relatively easy to straighten out. As soon as you've got a bent finger at the PIP joint, it's more tricky, and I'd rather see those sooner rather than later. So then the treatment options essentially are either to leave it alone, to explain to them that it's nothing nasty and they can get on with things. But if it's functionally limiting, then they can have a fasciotomy to divide the fascia, or a fasciectomy to take out the fascia. And occasionally, very occasionally, we might take the finger off, an amputation. And it used to be that you can either do a fasciotomy, so dividing the fascia with a needle in the clinic or in the theatre. For a while you could use collagenase, an enzyme that dissolved that. That's unfortunately no longer commercially available. Not that it didn't work, it's just that they made more money sticking it into buttocks, so they can't put it into hands anymore. But those are essentially the options for your patients. And needle fasciotomy has been used for a long time. You can either do it in the clinic or in theatre. And in my hands at least, this tends to be used for patients who've got a very well-defined cord, sometimes who need something quickly doing to restore function, who've got other things going on that mean you can't have anything bigger, or have got such an obvious cord that you just divide it and it sort of straightens out their finger. But there is a reasonably high chance of recurrence and reoperation. So if you look at this work, which is now quite old, the stats are still the same. The reoperation rate is high and the recurrence rate is really, 50-50. So in the right patient, it's a good thing to do. And particularly with the pandemic, where there's been restrictions in getting people to theatre, sort of to someone who's got a very bent finger to get it straight is really helpful. But it's worth riding that with the fact that they then sometimes need something else doing. So then this is a intraoperative photo of fasciectomy, and you can see why it looks like a tendon. So this is where the confusion lies. This cord here does look an awful lot like a tendon, but it's the pathological fascia. And a fasciectomy is just taking that out, often through a zigzag cut to allow the finger to go straight. And what you probably need to know is how long it takes for the patients afterwards. So the stitches that I use are dissolvable. The wound takes 2 weeks to heal, and then they need to get moving. And a lot of it's to do with the therapy that they receive afterwards. They might need to wear a splint to hold their fingers out, depending on what the contracture was like beforehand. But depending on what they do, they'll either be back to work between 2 and 6 weeks. But really, it's all about function. So this is Bill Nye, who's well known for having Dupuytrens. He's got really quite significant contracture. I don't know why he's left it this long. He's now reached a point where that's his trademark thing. He has bent fingers. And it just really highlights that some people function really well with very bent fingers. You don't have to operate on all of them, but there are things that you can do before they reach this stage, because surgically there's very little you can do to a finger that's like that. So that's bent fingers that don't go straight. There's another group of bent fingers that sort of get stuck, which is all about trigger finger. So with this, you've got a group of patients whose fingers catch, and they'll often say, first thing in the morning, my finger gets stuck and I have to pull it out straight. What can happen then is over time they can get so locked that they don't go straight. And I've definitely had a few patients recently who've either been referred with Dupuytrens and had trigger finger, or have had trigger finger and been referred with Dupuytrens, because when they're locked they can look quite similar. But essentially you've got the tendon that's moving your finger getting stuck in the pulley here, a little bit like a frayed rope going through the eye of a needle. The thing with this group of patients is they do really well with a steroid injection for the most part, so it's definitely worth trying a steroid injection. I don't know, does anybody in the room inject for triggers at the moment? So there's a few nods. The only thing to say is that it's less effective in diabetics. So that's a group of people who are a bit more sort of concerned about. But you've essentially got this lump here that's getting stuck at the pulleys. If the injections don't work, then they can have a surgical decompression. And the other thing that's important is that it's not uncommon for patients to complain of PIP joint pain and have trigger finger. So the two are sort of linked, in so much as if your finger won't go straight, if you hold it in a slightly flexed position all the time, you do seem to get some PIP joint pain. And similarly, post-op, once they can then move their finger fully, they quite often then complain of PIP joint pain. So the two can interplay, and if there's a bit of arthritis in the PIP joint, it makes it a bit more complicated. But it's worth examining somebody's palm to check whether or not they've got a nodule as they move their finger, even if you think it's just PIP joint arthritis, because sometimes, rather than them needing something to the PIP joint, they just need a trigger finger injection. We'll cover injections a bit later on. So trigger finger decompression is done as a day case. You'll keep seeing this abbreviation WALANT in hand surgery at the moment. It's an abbreviation from Canada, which stands for Wide Awake Local Anesthetic No Tourniquet. It basically means using adrenaline in the finger, which a few years ago was a massive no-no. So, you know, everybody knows you shouldn't put adrenaline in digits. But a guy in Canada called Don Lalonde looked into where this came from and did a bit of myth busting, and it turned out that in the 50s it was that people were using cocaine rather than lignocaine, and cocaine's not very good for your fingers. And so all these digits that were dying was nothing to do with the adrenaline, it was to do with the local anaesthetic. So he did this massive body of work, and there's some great photos of him injecting his own fingers. And you know, your fingers go white, and then they regain their blood supply again after a short period of time. But it means that you can do cases without a tourniquet, so it's much more comfortable for the patient. I had a physiology experiment at medical school where they made us wear a tourniquet for 20 minutes. It sort of scarred me for life. It's really painful. And if you talk to patients about having had a carpal tunnel with or without a tourniquet, they definitely prefer it without. So if you're doing things to patients with local, it's worth knowing you can use adrenaline, and it works really well. So that's what WALANT means. But the operation basically involves dividing that pulley, putting some dissolving stitches in, and getting the patient to move their fingers pretty early on. And they do pretty well, but it's just worth remembering that sometimes they will then complain of PIP joint pain afterwards because the finger that's been bent then is able to go straight. We'll cover injections a bit later on. So we've talked about bent fingers, we've now got tingly fingers. I think some of my colleagues think that all we do is carpal tunnel decompression, so you won't be surprised to hear a hand surgeon talk about carpal tunnel decompression. And I'm sure that all of you have seen patients with this. They have a classical history of waking from sleep and shaking their hands or dangling their hands off the end of the bed. Their thumb, index, middle and half their ring finger go numb, and sometimes they get some thenar wasting. So when you see them in clinic, they might have this picture here where I don't know how well that's projecting, but their thenar muscles are relatively wasted. It's worth trying night splints. So the thinking behind this is we mostly sleep, well, a lot of people sleep with their wrists in flexion, which is Phelan's test. So if you're sleeping like this, then you're putting pressure on the nerve, and so holding the wrist out straight overnight is worth trying. And a steroid injection, again, can be beneficial. But the other thing with that is that if they're diabetic, we know they're less likely to do well, but it's also important to control diabetes prior to surgery, because there is a group who do badly because they've got diabetic neuropathy anyway, and then if their diabetes isn't well controlled, they might get a post-op infection. So again, I do these without a tourniquet. They need to keep the wound dry for 2 weeks, and depending on what they do, depends on how long they get back to work, really. The return to work really does depend on what they do. Manual workers, it might be 6 weeks, and sometimes if you put a scar in the hand of a manual worker, whenever they're gripping things, it can be sore. So I do have a slightly higher threshold for the sort of men in their 30s who are lifting things all day, because you want to make sure that you've ruled other things out, and that you've done everything you can without operating on them, because the scar there is painful. The thing that often they do comment on, though, is that the sleep disturbance that they were getting with their carpal tunnel symptoms goes pretty quickly. So that, from that point of view, given that sleep deprivation is a form of torture, they do kind of well. So it's a useful operation. And the other sort of common cause of tingling fingers is cubital tunnel syndrome, so ulnar nerve compression at the elbow. And again, we probably all experience sleeping with our elbows very flexed and then waking up in the morning with a numb ulnar side of your hand. I certainly have. And so it might be positional. It's worth talking to patients about the position of their workstation. If they're working on the phone all day like this, that can make it worse. But when you examine them and do a Tinel's test around the elbow, they get shooting down the ulnar nerve distribution, and they might have weak intrinsics when you examine them. Again, they do pretty well. I think the only thing I've found is that patients who've had carpal and cubital tunnel syndrome, it's worth warning them that it's not quite as good as a carpal tunnel, or at least it takes longer to recover. The nerve's got longer to sort of sort itself out to the fingertips. And sometimes when you decompress the nerve's unstable, so you move their arm and it pings backwards and forwards, and then you have to transpose the nerve, which is a bit more involved. But again, it does get rid of their symptoms. So moving on to painful joints, orthopaedics in general sort of follows these principles, and my colleagues will talk about different variations of this for all of their talks really. Essentially, management breaks down into non-surgical and surgical treatment, and the surgical treatment, the options are always either remove, replace, realign or fuse. So the knee surgeons will talk to you about realigning knees, and hip surgeons like to replace stuff. You can't fuse everything, you can't fuse a knee. And some of these patients, if they need something relatively straightforward, you can denervate their wrist in particular. You just take out the nerve that supplies the wrist joint, and that can affect their pain without changing the bony anatomy. But those are basically the options that we have. And probably the most common thing that you'll see, because it's almost a part of normal aging, is basal thumb arthritis. It's very, very common. And it really does impact people's activities of daily living. You know, it's not something, you know, people really, you know, have difficulty doing the simplest of things, and it's really problematic. And there are things you can do to help them with activity modification, which I'll talk about on the next slide. The trapeziectomy is probably the most commonly performed operation for it, so taking the trapezium out. But there are also joint replacements in the right group of patients. So you can have what looks like basically a small upside down hip replacement. And in the right patient, that's quite a good thing to be aware of. But there are definitely options that you can do that will get rid of people's pain. This is what I was saying about activity modification. Slightly bad photos of my hands. What tends to happen, particularly if people have got long fingernails, is they pinch like this rather than like this. And when you're pinching tip to tip with, as is seen on the here, the forces are reduced in comparison with if you do pulp to pulp like this. So people with long fingernails can't really pinch like that. They're pinching flat. And it's not uncommon that you see ladies in their 50s with basal thumb arthritis and really long nails. And I often tell them to trim their nails. Not all of them are prepared to do it, but I've definitely had a number of them who've done it, and then they go through a period of exercises around a cone, so it teaches you to pinch like that rather than like that. And just by modifying how they're doing stuff can really affect their symptoms. So if you see somebody with long fingernails and basal thumb arthritis, particularly if they're in their 40s, they probably won't do it, but it's worth telling them that if they did it, it would help. And if you can get them to do some exercises around a cone, sometimes that combined with an injection is enough to get rid of their symptoms, or at least modify them enough that they can do stuff. So just bear that in mind when you next see somebody with long talons on their thumb. I saw somebody yesterday with beautiful purple long thumbnails and basal thumb arthritis. She wasn't going to chop them off, so she's having an operation. The other thing is about injections, and we'll talk about injections a bit later on. My preference is actually to do them in theatre, or at least to do them with an X-ray. So you can see the joint distending here. It didn't look like that before. That's because the injection that's going in there has distended it. And the reason for that is we know there's been quite a bit of work done on whether extra-articular injections help, and they do. But if you put the injection into the joint and that gives them an idea of what it's really like because it's from the joint, it really helps them with their decision making. Even if they only get pain relief for a couple of weeks, they know that that was where the pain was coming from. If you do an extra articular injection and that works, or you don't know whether it was extra articular or not, you're left with this slight, do we really know what was causing the pain? So my preference is to do them in theatre or to do them with an X-ray, but I do accept that not everyone can do that. And I think at the moment, when there's a long wait for things, there is probably an indication for doing a steroid injection in a clinic, and we'll talk about that a bit later on. But as I said, the trapeziectomy is probably the most commonly performed operation for painful basal thumb arthritis. And the main thing about this is to tell people that it takes a long time to get over. So it's not like a hip replacement where you do it and then they're fine and off they go. They're often unhappy. Well, I warn them that they'll be unhappy at 6 weeks. They're normally not so unhappy because I've warned them. But you're basically taking a painful joint and hitting it with a hammer. So it's a sore operation and it takes time to get over. But provided they understand that there's a reasonable period of rehab afterwards, they're usually pretty pleased by sort of 3 to 6 months. But it's not an operation to be undertaken without careful consideration. It's not a sort of, hi, how are you? Would you like a trapeziectomy? You have to sort of really work out how bad their pain is and be certain that that's where the pain's coming from, because it is quite an invasive thing to do to somebody's thumb. So we've talked about replacements in the thumb. There are also lots of small joints in the hand that can also be replaced with these things that look like mini knee replacements. You can annoy knee surgeons by telling them that, the good thing with being a hand surgeon is when you get old and can't see anything, you can replace a knee because it's like a big PIP joint. But apparently that doesn't go down well, I've discovered. And if you're really enthusiastic, we commonly put MCP joints and PIP joints in. If you're super enthusiastic, you can even get a small PIP and stick it in a DIP. I've done it a couple of times. It's not something I find particularly rewarding or helpful, but Jay, fortunately, is very good at it. So if you have a patient who wants a DIP joint replacement, Mr. Panic is your man, and he'll do that for them. And they do quite well, actually. This is an example radiologically of what we're doing with PIP joint replacements, and you can see on the left quite significant degenerative change of the PIP joint, and then these sort of mini knee replacements on the right, and surgeons always show their best results. So this is a series of patients that I looked at when I was working with Jonathan Jones in Peterborough, and you can see, post-operatively their range of movement is excellent, and they have good pain relief. This particular PIP joint squeaks, so the patients don't always like it because every time they bend their hand it makes a noise. But the important thing with that is that when you look at the results of these, they don't gain movement. So what you tend to do is you take a painful moving joint to become an unpainful moving joint, but you don't gain movement. It's tempting to think that you take out the arthritic joint and then they'll get more movement, but they tend not to. So if you've got a patient who's got a stiff, painful PIP joint, it's better to fuse it than to do a replacement, because their expectation is that they'll get more movement and they don't. So that's an important sort of message to have. But they do really well from a pain relief point of view. And over time we're moving the joints. Every once in a while someone produces a new mini knee replacement. But they do quite well from a pain point of view. The other option with painful joints is to fuse them, and so this is what I tend to do for a DIP joint rather than replacing it. And also with the index finger, so when you pinch against your index finger, there's a force that's ulnarly directed, so the stress across your PIP joint of your index finger is much higher than it is in your other fingers, which are relatively protected by the ones on either side. So quite often with an index finger, I'll fuse the PIP joint if they have quite high demand, because the ulnarly deviated force will ruin a PIP joint replacement in the index finger quite often. Let me talk briefly about DIP joint replacement if you're keen. Obviously there's a whole load of causes for painful wrist, and I'm not going to cover them all, you'll be pleased to know. But there's a whole load of different diagnoses and different things that we can do, but they slightly fall outside the scope of this talk. The only thing to say is that in the population around here, there's quite a lot of patients who've had wrist replacements. You may have patients in your practice who've had these done. My predecessor was very enthusiastic in putting them in, and they do work quite well in the right patient. There are also some who are coming towards the end of that sort of working life of that joint. And if you've got one who's got a painful wrist replacement, just send them back in and we'll see them. There are some who seem to have slightly been lost to follow-up during the pandemic. And struggling on with wrists that don't really function anymore, because this, like any other joint, will wear out eventually. So just be aware that you can do them, but also that they can fail, and I'd like to see them if they do. You can then obviously fuse, as we talked about the options for joints, you can fuse them either the whole joint or part of the joint. And there are replacements for the distal radial ulnar joint in a very few patients that do quite well. So that's painful joints. The next thing to cover really is lumps, so lumps that affect function. And it's quite common to see people with lumps around the wrist, which can be painful, they can be cosmetically awkward. But whether people articulate it or not, often the question that the patients have is this cancer? That's what they're really asking. I've got this lump and it's sore, is it cancer? And I think people are often referred in as having ganglia, but they're not always ganglia. So it's just to give you a few things to think about when you see somebody with a lump around the wrist. There are 4 sort of common sites for lumps that are likely to be ganglia. So on the dorsal-radial aspect of the wrist, on the volar-radial aspect, and you'll have all seen these sort of near around the base of the thumb. Pearl ganglions you get in the palm of the hand either side of the MCP joint. And they, particularly if people are doing manual work, they can be really awkward. They go to sort of move their fingers and it feels like, and that can press on the digital nerve. So it can be associated with tingling and numbness. And also mucous cysts, and I'll illustrate that with a picture in a minute. And if it's not in one of those places, it's probably not a ganglion. So I've got ET, everyone's favourite extraterrestrial. Just to remind you of Alex's law, this is Alex Cacetta. He does a whole talk, or you could add half an hour on just ganglion. But his rule is if it's not a ganglion if it doesn't transilluminate. So if you shine a pen torch onto the lump around the wrist and it doesn't transilluminate, it's not a ganglion. And so that might then frame how quickly you try and get them to see us. So it's worth, if you can get hold of a pen torch or the back of your phone, shining it in. And if it is a ganglion, it will light up like that. So treatment of wrist ganglia, often they just need reassurance. This is probably just a ganglion, particularly if you've got one in a classical position and you shine a light on it, then you can be confident that it's a ganglion. The traditional teaching was to whack them with a family Bible. It's not uncommon for patients to come in and say, somebody said I could hit it with the Bible. You can hit, other books are available. When I was a medical student, I was in a hip surgeon's clinic and somebody came in with wrist pain, and a very prominent hip surgeon looked them in the eye, held their hand with both of his quite strong hands and pushed hard. It gets rid of the ganglion. It causes a lot of pain. Don't ever do it. So you can whack them or squeeze them, but don't. Aspirating them isn't really very helpful. They tend to come back. But sometimes that's all the patient wants to have done. If people do have an operation on them, it's worth being aware that there is a reasonably high recurrence rate. So surgery isn't necessarily the be-all and end-all. And my main concern when I see people in the clinic with a ganglion is this definitely a ganglion? And is there an underlying carpal pathology that's causing this? Because quite often you'll go and just take out the lump, but you've not sorted out the scapholunate problem. And then their wrist pain, which is why they came to see you in the first place, is not solved. So that's what I spend a lot of time doing. This is just a photo of a mucous cyst, which hopefully many of you will have seen. It comes from the DIP joint. So this lump here is associated with the underlying joint. And that's important because it's not uncommon for patients to stick things into them. Sometimes people stick things into them for them. So they've been and seen somebody who's stuck a needle into it. Don't do that. I encourage them not to do it. Because what can then happen is they get DIP, joint septic arthritis, because whatever was on the skin ends up in the joint, and then they end up with shorter fingers. So yeah, it can cause ridging of the nail. So the nail bed is here, the germinal matrix where the nail grows from is here, and the pressure of this pushing on the germinal matrix gives them ridged nails. That when you take the mucous cyst out, that ridged nail sometimes goes away, but it takes about 6 months for that to happen. But it's just being aware that that's what a mucous cyst is. Oh, don't worry, I'm not going to try and do the whole of rheumatoid hands in 5 minutes, but essentially you've all seen patients with rheumatoid arthritis with classical MCP joints that are swollen, ulnarly deviated fingers, radially deviated wrists, and potentially swan neck deformities or boutonniere deformities. And it's just really saying that we see quite a few of these. Fortunately, as the treatment for rheumatoid has improved over the years, you tend not to see the really, really bad ones because the drug treatments have improved. There are a load of things that can be done, but it's all about teamwork, so working with the rheumatologists, and it's all about function. So this is a radiological example of somebody with sort of classical changes on the left side, and then the fingers have been straightened out, having had MCP joint replacements and some selected fusions. And that does make quite a big difference to people's function, because rather than their fingers being off to one side, they can grip again. One of the things with this is it's tempting to look at the x-ray and just think it's about what we've done to the joint. It's actually probably more to do with what we do to the soft tissues. So it's about straightening up your fingers again, which isn't just about chopping out the joint, it's about rebalancing the tendons. And again, I'm not going to say a whole load about hand trauma, other than to say that there are 3 of us here. There are 3 hand trauma lists a week, which is with slots set aside for hand trauma, and we cover all of hand trauma, apart from replants. So if somebody comes in with a finger that they've chopped off, it's best to let them go to the Northern, not because we couldn't do it here, but we don't want to be on call 1 in 3. And so we outsource that to the Northern because they don't come in very often. But this is somebody who's cut their flexor tendons, and you can see the cascade here is gone with the cuts here, and then once you repair them, they come back. And so we cover all aspects of hand surgery trauma here. I just mentioned this because you might be on the side of a rugby pitch, or you might have small children who are doing things, or you might come across somebody with an obviously dislocated finger. And it's just worth knowing particularly if it's a dislocated MCP joint and you have this sort of puckering here. Don't just pull on the finger. It's the most common thing to do. You see a dislocated finger and you think, well, I'll just pull on it and it will go back. What happens is you get a lasso of soft tissues around the metacarpal head, and pulling on it makes it worse. So what you need to do is you need to find a friend and get somebody to flex the wrist, which takes the tension out of it, and then you can glide the finger back. And if you do that, it goes back quite easily. But if you just pull on it, it just makes the whole thing worse. So if you're on the side of a rugby pitch and somebody's child comes along with an obviously dislocated finger, just get someone to sort of hold their wrist flexed and talk to them while you just slide it around, and it will go back quite well. But if you pull on it, it makes my life harder. So hopefully that gives you some ideas, some things to sort of hang your hat on when you see some patients. I think it's a truism, but it's also, it's a fact that if you only see one thing, that's what you keep seeing. And with hands, it's all about function. So yeah, we're all three of us are very happy to have people in clinic. We're very happy to talk things through, pick up the phone, send us an email, and we'll very happily see your patients. And I think it's important to acknowledge that the drawings here aren't mine. So these great drawings are by a hand surgeon called Donald Samet, who's a very gifted artist. So his website's worth looking at. Actually, some of the things that he does are quite fantastic. He does some missionary work out here, or some voluntary work out in Nepal. And the BSSH, I always tell patients if they want more information, because they always come and they say, I've looked it up and I've seen an American website on carpal tunnels and now I'm terrified. And so I advise them to go to the BSSH website, where there's some really useful patient information leaflets, and I direct patients that way. Are there any questions at this point? Does anybody have any thoughts or questions? So the second half of this is really about injecting the hand. Does anybody in the audience already inject? Is anybody doing injections regularly? A couple? So as was said right at the start, I can't teach everybody how to inject from here. So this is really about things that I do, hints and suggestions, and because there are three hand surgeons, we probably all do things slightly differently, but it's really to give an opportunity to discuss it further and to have a practice at finding landmarks on one another. And so what I'm going to get you to pair up. You won't have to inject one another, but you can practice where you would inject one another. So the common indications for injections are for trigger finger, and we'll talk a bit about why that's a good thing to do, but it's definitely worth doing if you see somebody with a trigger finger. Basal thumb arthritis, I've touched on. I think certainly whilst there's such a long waiting list for something to be done, if somebody's got a very painful thumb, putting a steroid around the base of their thumb is not an unreasonable thing to do, but it doesn't always go into the joint. It might give them some relief, and it's worth being aware how to do it. Quervain does respond well to an injection, and we've talked briefly about carpal tunnel syndrome at the end. There are other things you can inject, so this is an illustration of intersection syndrome, but you might inject for diagnostic purposes as much as for pain relief. So if you're injecting into a small joint, just to see whether that's really the source of their pain, if there are a number of other joints that are painful around there. And if people have got tendinitis, so they've got an inflamed ECU, injecting around that can really help. So it's important to know whether what we're going to do is going to help. So trigger finger does improve, more than half the patients that and quite often you'll inject them and it will solve the problem. The pandemic's been really interesting from a trigger finger point of view. Because there's been so much delay in people being seen, or they've not been seen face to face, or they take a while to see me, or take a while to see me on the waiting list. There are definitely patients who have got quite bad triggering and it gets better over 3 months or 6 months. So they'll come and they'll say, well, when I went to see my GP, my finger was getting stuck and now it's fine. Or you put me on your waiting list 8 months ago and now it's okay. So it is definitely something that I feel that we've become a bit more uncertain about as we've given longer to the natural history. And so it's worth making sure that it's trigger finger and not Dupuytrens, and it's worth trying an injection. Again, the comments about diabetics stand from before. Again, with carpal tunnel, I think there's different people. If people come in with numb fingers and weak thenar muscles, then I don't think injecting them's necessary or a good idea. But if you've got relatively early carpal tunnel that's responding to splints, and they've got intermittent night symptoms, then I think giving them a local anaesthetic and steroid injection might help. but doing it twice probably isn't recommended. And again, you want to make sure you're injecting into the carpal tunnel. As I mentioned before, de Quervain's does pretty well actually with an injection. The only thing to say with that is if you've got access to an ultrasound and somebody who can do ultrasound and inject is even better, because the tendons, there can be more than one tendon and it can run in more than one sheath, and so you can inject one of them but not both, and then it doesn't get better. So sometimes the de Quervains that fail are because you've only injected one of the slips of the AP. How effective your basal thumb injection depends on how bad their arthritis is, unsurprisingly. So these are the things that I use when doing it. Everybody does it differently. There'll be a number of you in this room who, if you're injecting, just mix everything together and put it in. I know my predecessor did that. My preference, and I would suggest if you're injecting for the first time to try, is to put this local in separately to the steroid. Because if you get some local, I use 2% lignocaine and the smallest needle that I can. If you get a relaxed patient with a hand on a pillow and you pinch the skin and then slowly inject the local, it's not that sore, and then you can then inject the steroid without worrying that it's going to hurt the patient, and it's much more comfortable. So that's my personal preference. I tend to use the same syringe to try and save on plastic waste, but I don't leave the needle in. I just sort of inject take it all out, and then draw up the depomedrone. The other reason for doing it like that is it stops me from rushing. If you have them both drawn up, you might as well stick them both in together. But if you wait long enough to draw up the depomedrone, the local probably will have worked by the time you stick the next needle in. And it's a lot of injection technique is about you and the patient being comfortable. In practice, what I usually do is I get up to wash my hands and I advise the patient to do the same. Some patients come to my clinic with pretty grubby hands, and then use an Alco wipe as well, pinch the skin to take out the tension, put in the local, and then put in the depomedrone. I also make sure there's somebody within shouting distance, ideally in the room, and somewhere you potentially can lie a patient down, because the patients who you least expect to faint in the middle of a busy clinic are the ones who go green and keel over. So that's, yeah, the people who look like they're going to faint don't necessarily faint, and some of the big people who say that they're fine need to have a little lie down. So just make sure there's somewhere you can put them. And it's always when the clinic's running late. So trigger finger, the point about the anatomy here that's interesting, so what you're trying to do is to infiltrate around the A1 pulley with your depomedrone to try and reduce the swelling so that that threaded rope can go through the needle more easily. The distance between here and here is the same as the distance from this crease to the A1 pulley here. So if you're looking at your hand or your patient's hand, you just want to basically have a look and see that distance and then take it further back there, and that's where you want to inject. And that was an anatomical study that was done a few years ago, and it's quite a useful sort of landmark to know where to head. This illustrates how someone else does it, but essentially I put the local in here, take everything out, draw up the depomedrone, and then inject in this site when it's numb. And I tend to inject through the tendon, so you stick the needle right the way through and then pull back slightly, and it will flow freely. If you've got resistance, you're probably in the tendon, so you don't need to do that. So you're in sort of pairs. If you introduce yourself to the person next to you, if you don't know them already, and then have a look at one another's hands and just make sure you know where you'd be injecting. Okay, so so the next thing to move on to is just looking. Were there any questions from that? You've worked out where you think the A1 pulley is. Happy? Yeah. Plenty of nods around the room. So basal thumb injections. Again, we talked a bit about this. My preference is to do them in theatre, but you can do them in clinic. It's very difficult to get a needle into an arthritic joint. It can be hard enough in theatre with an X-ray. It is pretty difficult to do it blind, but people do get some pain relief from sticking an injection around this area if they've got very arthritic thumbs. So if you indent this in just the skin, just proximal to the joint, and it's really about, again, I would use the local at this stage, and you're injecting outside the capsule to make that area numb, and then inject through a bleb of local anaesthetic. the only other hint that's worth knowing is if you put their hand over something, so put a towel or something here and then pull on the thumb, it's easier to get in. The times that I found it difficult have been when the hand is in that position. It's just everything's a bit kind of cramped. So you want to extend the wrist slightly or ulnarly deviate it. And then if you're fortunate, you sometimes will feel it go into the capsule, and then when you inject, after you've got about 0.5 mil in, it feels some resistance and it feels uncomfortable because you're stretching a painful joint, and stretch is a component of pain. But you won't get more than 1 mil in because that's just too sore. As I say, it's easier to do that with an X-ray. So if you again examine one another's thumbs and just work out where you'd be sticking your needles. While you're examining one another's thumbs, you might notice the MCP joint, so the joint just above that, interestingly is one of the joints with the most natural variation in the body. So some of you will have MCP joints that flex to 90 degrees, and some will barely move at all. So it's worth looking at that just to see the amount of variation there is in that. The reason that's important is if you've got a hyperextending MCP joint and basal thumb arthritis, that might need to be addressed at the time of surgery. So the next thing to look, which you can do on your own hand, is to look for where your de Quervain's tendons are. So if you put your hand out in front of you and you lift your thumb backwards like this, that movement's called retropulsion, and it's done exclusively by extensor pollicis longus, which is the tendon that runs around Lister's tubercle on the back of your wrist. So after somebody's had a wrist fracture, it's worth examining to check that they can retropulse their thumb, because if you can't do that anymore, if the tendon's ruptured, you might need to do a tendon transfer. So EPL is the tendon that retropulses your thumb. And then next to that, EPB and APL. So EPL is extensor pollicis longus, extensor pollicis brevis, and APL are the two tendons that form the de Quervain's tendons, which is the first extensor compartment here. And the APL, the abductor pollicis longus, can have multiple slips, and that's the one where if you do an injection and it doesn't work, it might be because you've only got one bit of that rather than all of the slips where they run in separate compartments. So that's what you do there. Carpal tunnel injections, I think, oh sorry, go on. Yeah.
So if you've done a landmark guided injection to the first extensor compartment and it wasn't successful, ultrasound guided, who does that here?
That's a great question. When I find out, I'll let you know. Okay. So yeah, it's one of the challenges is we don't currently have that in place regularly here. So if I'm uncertain diagnostically, I'll send them off for an ultrasound anyway. But unfortunately, we don't have an ultrasound guided injection person here on site. So yeah, but if anybody would like to develop that service with me, come and find me afterwards. Yeah. And then carpal tunnel injections, I think, probably fall outside the scope of this. It's very difficult to do that from the front up here, but we do run lots of clinics that come along and we can inject some patients' carpal tunnels. Essentially, you need to go to the ulnar side of palmaris longus. So if you take your hand and stretch it out, you'll find flexor carpi radialis going over your scaphoid tubercle, and then next to that in most people there's palmaris longus. It's supposed to be absent in 10% of the population. I think there's probably more people that have it than that. But essentially you want to not inject into the median nerve. And it's, if you're happy, once you've done it a few times and you're happy doing it, it's a really useful thing to do, but I'm not going to try and teach it to you from the front of a lecture theatre because that's probably not a good idea.
Can I ask how many carpal tunnels do you inject? So I know historically Alex has tended not to.
Yeah, I probably do more than Alex does. Yeah, and yes, so and that probably reflects practice that I had elsewhere, because if you catch them early, there are some people who don't need an operation, and also there are some people who, part of it's a rationing thing, so the waiting list is long. So the problem is you've got someone in front of you who you could do something for, or you say, well, I'll put you on the waiting list knowing full well that'll be, you know, a few months. And if you inject them, they might get some sleep. I don't inject them and send them away. I inject them and see them again at 2 months. And I think that some of those, if they're early, it does solve the problem, but I always give them an open appointment to come back. But I've definitely had, for 4 years I ran a practice with a carpal tunnel clinic with sort of 8 or 10 people a week. We trained up a therapist to do the injections, and there are some people who you're delaying the inevitable, and that's not a good thing. So if they've got thenar wasting and they've got persistent symptoms, they need something doing. But I think there is a group of people who actually do quite well with injections. And it very much depends on whose papers you read. There's a group of people down in, I think, Southampton. And they treat a whole load of people without injections. The problem with injections. But the problem is that we have you can have a reinforcement of your own prejudices. So that's why it's quite useful having people who have different opinions, because we work in tandem. I don't think Alex and I would disagree on the ones that definitely need it. But I think probably there are some people who come to see me in clinic who get an injection who then maybe don't get an operation. But it does vary. I think the other strange thing about carpal tunnels is there are people with bilateral carpal tunnel, and you operate on one and their symptoms on the other side get better without you actually doing anything to it. So it's not totally, and that's definitely a thing. I've seen this enough times to know that's a thing. But it doesn't make any sense. And I think that you have to have a bit of humility and say, actually, there are some things about this that we don't really know. So you have to do what's right for the patient in front of you. And sometimes in my hands, that's an injection. But I take your point.
Historically, we've kind of said, oh, we can offer the
yeah. Yeah. Yeah, perhaps we need to have a chat. It is really difficult in this context to give a sort of single answer to that question, but it's an important question, I think. Yeah. Hopefully that's not just confused everybody in the room, but it's an important thing. With any intervention that we do, we need to warn people about the things that could go wrong. It's worth being aware that you can damage stuff. The other thing is that if you inject steroid beneath the surface, you can change the colour of the skin. And if you don't warn people of this, particularly with the Quervains, and they come back with a whiter area where you've injected it, they don't necessarily like it. And so just be aware that if you're sticking steroid into skin, it can change the colour of it. And there's also something called a steroid flare. So you inject steroid into somebody and 2 days later they've got this really red, painful bit where the steroid's been. And it's not an infection, it's just a response to having had decompression put in. So again, I always warn people about that before doing it. It's also possible to rupture tendons with injections. We've mentioned fainting, which isn't a good thing. So I think that's it from me. Are there any questions from anybody?